in the passing of former Commission President and City Council Leader Bill Rosendahl, and in his honor, we're convening and adjourning this evening's meeting. And thank you, Commissioners, for suggesting that as part of the agenda process. With that, we should begin with agenda item number 1, which is a presentation on health-related costs, programs, and policies. The best way to run this that I'm proposing tonight is that we have each of our speakers share with us 7 to 10 minutes of remarks, and if commissioners could each do 1 round of questions, and we'll see how much time we have to entertain additional questions. In respect for all of your time and the time of the presenters, let's try and keep things moving along, and we can, and I take responsibility for, follow up on subsequent questions or topics we haven't been able to address during this time. So without further ado, I'd like to invite the Parks for All campaign to please come and join us here at the table. Please introduce yourself. If you have materials, I'm happy to distribute to everyone. Well, please come take a seat. We'd be happy to have you up here. No need to stand for 7 minutes there.
I think we need to approve the minutes from last time before we start.
We're missing anything we skipped in the agenda?
Yes.
We have to approve the minutes.
I move to approve the agenda. I mean the
minutes.
I also do the minutes from the last meeting.
Second.
All in favor?
Aye.
Opposed? Abstain? Minutes are approved as presented and written to the Commissioners. So thank you, Clerk, for providing that, and thank you, Commissioner Mandel, for making said motion. Now, without much further ado, please introduce yourself, tell us about your organization, your objectives, and what we need to know and do.
Sure. Is this mic? Yes, it is. And did you pass out the handout? Thank you.
Everyone will have a copy momentarily, so feel free to begin.
Great, thank you. Well, good evening, Commissioners, and thank you for this opportunity. My name is Elsa Tung. I'm the Policy and Research Manager with the Los Angeles Neighborhood Land Trust. The Land Trust was founded by a city task force in 2002 to respond to the critical lack of urban parks and gardens and green space in LA's low-income communities of color. So we are both a park developer with 22 completed park projects and another 9 in a development pipeline, as well as a park advocate with a particular focus on park equity. Now, I know this commission knows very well the many, many health benefits of parks and the deep disparities in park access and quality that exist across the city, so I won't spend too much time on this, but just a really quick example. In South LA, specifically Southeast LA, has a staggering 500 times less park space per population than Brentwood, Pacific Palisades. Now, these same 2 areas of the city, Southeast LA and Brentwood, Pacific Palisades, have one of the city's largest gaps in childhood obesity and an unconscionable gap of 12 years in life expectancy. So to us, parks are not only a matter of public health, they are a matter of civil rights. Now, a few years ago, the Land Trust started to move into the policy arena and decided to take on the LA Quimby Ordinance, which has been plagued with problems for several decades now. So in 2014, we released this policy brief. Now, you have basically an executive summary in your packet, the last page of your packet. We released this policy brief containing 6 concrete policy recommendations to improve the Quimby Ordinance. So what is the Quimby Ordinance besides kind of a funny sounding name? Well, it's based on a 1965 state law that requires housing developers to either set aside land or pay an in lieu fee that goes towards building new or improving existing parks. So it's what's known as a development impact fee, which is intended to mitigate the impact that new development and new residents have on the city's park system. So Quimby fees are a significant source of funding for park capital projects that includes land acquisition, construction, and repairs. But there are 2 key problems here. First, the funds are trapped, so some of the funds at least are trapped because of the geographic spending limitations of the existing law. This is the radius issue that I'll get into in just a few minutes. And secondly, the second problem is that the fees are severely outdated. They've not kept up pace with the skyrocketing costs of park development, particularly land acquisition, and they don't cover the actual costs of building new parks. So the bottom line is, if we want more and better parks in LA, and particularly if we want more equitably distributed parks, we have to fix Quimby. So just a little bit into the process and timeline. Following the release of this policy brief in 2014, we formed the Parks for All Coalition to advocate for our policy recommendations. And to date, we have 48 coalition members from a broad spectrum of public health, environment, and social justice organizations. A full list of our coalition members is in your handout packet. It's the back page of the first page. Now, around the same time in 2014, the City Planning Department was working on developing a new ordinance to reform and replace the outdated Quimby ordinance. The Planning Department's consultant was Ramey and Associates, which did this work as a follow-on to the Plan for a Healthy LA. Now the ordinance has been developed. Now, fast forward 2 years, the ordinance has been developed and is moving quickly. It was just approved unanimously on March 24th by the City Planning Commission. The ordinance now heads to PLUM, which is the Planning and Land Use Management Committee of City Council, where Committee Chairman Jose Huizar is championing it. And we expect PLUM to consider the ordinance sometime in May, so really just in the next month or so. Now for the second half of my presentation, I'm going to direct you to the second page of your packet, which is basically, it discusses particular policy issues that we're looking at right now in the current ordinance. First is the radius issue that I alluded to a few minutes ago. This is the allowable distance between where a fee is generated, which is a new housing development, and where the fee is spent, which is a new or an existing park. Now, the state law requires there to be some sort of reasonable relationship or a so-called nexus between the source of the fee and the spending of the fee. But the existing Quimby law is extraordinarily restrictive. So for a neighborhood park, they require the spending to be limited to within a half mile of a new development. For a community park, it's limited to within 2 miles of a new development. And obviously, as we all know, given a city the size of LA, these are extraordinarily tight circles around new development. You don't hit very many neighborhoods at all with a half mile or with even 2 miles for a slightly larger community park. So we've been pushing to expand the flexibility of this spending. The spending has essentially, what was uncovered in a 2008 audit was that the spending has been held up in this pot of money with the City Recreation and Parks Department because they can't spend at least some of it according to these very tight spending restrictions. So we've been pushing to expand the flexibility in the radius. And the proposed ordinance has exactly our recommendations, which we're very happy about. We pushed especially on the neighborhood park issue. So the neighborhood park radius has now expanded to 2 miles. The community park radius is 5 miles, and there's a new regional park radius that is 10 miles from a new development. With this one, we're generally optimistic and supportive of a regional park spending radius, but we want there to be some sort of requirement, whether it's legislative or administrative, to prioritize the areas of the city that have the greatest park needs. I'll leave that up there, and I'll hopefully yield some questions at the end of the presentation. The second issue, and this is perhaps the biggest issue or the one that has the most controversy behind it, is the fee. Now again, this is a development impact fee policy. So in the existing Quimby law, the fee is charged on subdivisions only. That means for sale units. Essentially, that means condos. And the fee schedule is based on zoning density. So the highest density zones have the highest fee, and the lowest density zones have the lowest fee. And you'll see here it ranges from a high of about 8,000 to a low of about 2,700. What is in the new ordinance is actually an entirely new fee structure. The fee, first of all, is charged on both subdivisions and rental units. So we've expanded the pool of developments that are charged a park fee because, of course, any apartment building and any new residents that come into an apartment building are going to have the same kind of park impact as a condo building. So the type of development shouldn't really matter in terms of the park impact. So now the fee is charged on both for sale units and rental units. And the fee schedule is based on the type of unit, a subdivision unit or a rental unit. And so this number here in the middle column, 10,000 and 5,000, I'm going to kind of give you some more context about where those numbers came from. Actually, let's shift over to the very right column, which has 12,500 per unit and 7,500 per unit. These were the numbers, 12.5 and 75, were the numbers that came directly from the city's fee study. The city did this fee study that said, okay, what is the maximum fee that could be charged to solve our city's park acquisition and construction problems for the next 20 years? What's the maximum fee? That maximum fee is approximately 18,300. And then the city did a feasibility study, which means, what kind of fee levels can developments feasibly, reasonably absorb into their development costs? And so the city came up with, the planning department, Ramey and Associates, came up with 12,500 and 7,500. And these are the numbers that our coalition, Parks for All, is supporting. Now, however, what's in the new ordinance is a notch down. It's 10,000 and 5,000 per unit, and that's because there are now two fee programs, kind of fee ordinances potentially on the table. First is ours, which is ready to go. It has legs. The second one is a proposal that was announced by the mayor several months ago for a linkage fee for affordable housing. It's essentially the same kind of mitigation fee that would go towards funding affordable housing. Obviously, as a coalition, we are extremely supportive of any sort of local funding stream for affordable housing, including this linkage fee proposal. But right now, these discussions have affected the fee levels for the park fee. Essentially, the argument is that, let's make room for an eventual affordable housing fee because it's going to happen in the future. To us, this is a preemptive cut. It doesn't make sense to cut something that is concrete, that is already been studied by the planning department, in order to make room for a proposal that doesn't yet really exist. It only exists in thought, I guess. The city is about to, I believe, hire the consultant to do the fee study. So it hasn't been studied yet. So to us, we want to restore the fee levels that were recommended by the planning department's fee study, and that is 12,500 per unit and 7,500 per unit, which the planning department has justified as these are the amounts that developments can feasibly absorb. So we think that these precious dollars should not be left on the table. These should be used to bolster our not first in the nation park system, but 51st in the nation park system. these fees that we're recommending at 12.5 and 75, they're right in the middle when you compare cities across California, and they're far below cities like Glendale, Pasadena, and San Jose. So with that, I look forward to your questions, and we hope that the City Health Commission can endorse our Parks for All campaign, knowing the significant health ramifications of a park system. And together, we hope we can build a healthy, livable, equitable city. Thank you.
Thank you, Ms. Tung. Thank you for taking the time to join us this evening. I hope you can stay for a few minutes for some questions from commissioners, beginning with, on our side there, Commissioner Hisrich.
Hisrich, yeah, hi. I just have to tell them so they know. Just a couple of quick questions. Sure. One is on the fee schedule. If a developer is putting together something that has some market rate units and then some subsidized units or lower access, did you want them to pay the same fee either way, or could they pay a lower fee for the units that are affordable, if you will?
That's a great question. I didn't actually, this original matrix here on page 2, I originally had our affordable housing explanation, but I decided to cut that for today's presentation. But affordable housing units essentially are exempt from paying the fee.
Okay.
So with a mixed income with a mixed income development, the market rate units would pay the fee, but the affordable housing units would be exempt.
Okay. Second question, neighborhood parks. Is that what we generally think of as these pocket parks that are maybe a block or so? And how much are those used in the context of things? I mean, you can't really play ball very much. You can throw it around, but you don't have a field. Are they effective for the community versus, let's say, more of the community parks and so on?
Sure, yes. Neighborhood parks are generally what you would call a pocket park. They're what the city's Rec and Parks Department is trying not to do is not trying to define it by size, but rather by its use. So it's generally used passively. There's not big recreation facilities, as you say, and they do, they are neighborhood parks where people live, close to where people live. Sorry, what was the second?
Well, no, that was really, I'm just trying to understand those versus using the funds to develop more regional parks, not regional, but community parks, which I think might have wider usage. But you find that the neighborhood parks are used pretty effectively in communities?
Neighborhood parks, we think, as a park developer and someone who's looking at this from certainly an equity standpoint, we think neighborhood parks are actually a key solution to resolving some of the inequities in park distribution, particularly when you think about the context of the extremely built up and built out city where you don't have a lot of available land to put together a large community park of, a football field, a soccer field, a basketball courts. What you do have is these small lots, these small parcels of vacant land that are ripe for park projects and greening projects, scattered all throughout the city, and particularly scattered in more abundance than we'd like in low-income communities. So we think neighborhood parks are actually a key strategy.
Thank you. Could you just go around this side? Yeah. Commissioner Sparks?
Yes, you mentioned that funds are being held up by Recreation and Parks. How much is that? Are the funds being held up because of the existing Quimby law?
Sure. Unfortunately, I don't have the numbers off the top of my head, and I don't want to give the misimpression that funds are being holed away by Recreation and Parks and not trying to be spent. Funds are trying to be allocated. It's just that the law right now limits some of that allocation because of the radius issue. But I will absolutely get back to you on the dollar amount that is essentially either held up or sort of has been difficult to allocate.
Thank you.
Commissioner Mandel? Dr. Mandel?
Thank you for your presentation. Question I have is a hypothetical question. and partially economic. So these fees have to be passed on. So a developer, say, in a middle-income community in Los Angeles, takes a dilapidated building, tears it down, and builds whatever number of units. Let's say 20 units, 30 units, times 10,000. They have to come up with that cash. That cash has to be transferred from a developer's point of view to the fees that they charge, i.e. there's positive pressure to increase your rents. So in the middle-income neighborhoods, you actually increase rents for a developer to be motivated to do any project. Otherwise, they'll just go elsewhere. In poor communities, which are the ones that are the most in need of parks, you actually disincentivize development. So what you end up having is what we're seeing in Los Angeles, is that in the wealthy communities, where you can justify outrageous high rents, and we have currently 98% occupancy in our rental units in the city of Los Angeles. So what you're having is actually a motivation for developers to go away from the communities we're trying to help and improve development. And you're disincentivizing and or increasing cost pressure in the middle income communities. And you're encouraging basically developers to only develop in the communities that are high income and or could justify high rents. So it actually works against what you're trying to do from a pure economic point of view, supply and demand.
Thank you. We've absolutely considered these points. We think that in terms of the development in the lower income communities that we care about the most, development's not happening in any case. I don't think this is any further change or disincentive in that. Developers largely are looking into, like you said, the middle income and the higher income areas. The city's fees study done by the planning department looked across the board at different types of development prototypes. So they looked into basically high income areas and middle income areas, using downtown as a high income area and parts of the valley as middle income areas. So the the fee levels that they recommended and that we are pushing is $12,500 to $75,000. Those are fee levels that have already been essentially vetted by the consultant to say that developers can absorb these costs. They're only 2%, approximately 2 to 3% of total development costs. So the planning department's fee study has taken into consideration the various development contexts of the city and has determined that the fee levels are justified.
I'm not a developer, but I would say that perhaps you should sit down with a bunch of developers, because one of the reasons you're not getting development in the poor communities is directly related to the fact that developers are going to follow money. Costs are going to be transmitted. And investors, 2 to 3%, where the current inflation rate is what it is, are the difference between 2 to 3% is the difference between profit and no profit. So you're actually hurting what your desired goal are. I'm all in favor of doing everything we can to have more parks, especially in the poor communities in our city. But I actually think that maybe you should go to UCLA or USC and get some of the economists involved and have them look at your proposal, because maybe you should go back to the drawing board and think of another way, because I think you're actually disincentivizing new development in the communities that need new housing. You're actually increasing the amount of homelessness in the city of Los Angeles, which we all know is the worst city in the country for homelessness per capita, and you're actually decreasing because all your revenues for your parks are coming from development. Well, most of your revenues are coming from development. You're actually hurting your desired goal, which is to put parks in the poor communities.
Well, thank you for your comments.
Thank you.
Oh, although I do want to mention that, again, the fee study looked at the feasibility and developer profit margin. So they determined that these fee levels that are recommended are still enough to maintain, I believe it's between 10 and 15% developer profit margin.
Could you send us that report? Is that possible?
The fee study?
Yeah.
Yes, absolutely.
Thank you.
Any other questions for Ms. Tung? Commissioner Jaquez.
Question for you. So thank you so much for the study. It's really very comprehensive and definitely needed. As you're aware, the areas that are predominantly park poor are the lower socioeconomic populations, issues with environmental justice issues. Okay, thanks. Is there anything being done to augment the whole issue of air quality? If you look at the southeast portion of Los Angeles, where that's very park poor, very dense. However, you have the issues of smog in the Alameda Corridor and the environmental impacts on that. Is there anything that you're working in conjunction with any other partnerships to address that issue as well?
In terms of park development in areas that could potentially have poor air quality?
Yes.
That's not the focus of our campaign currently, though we do know it's a large issue, and I do know that the USC Keck Environmental Health Division has been doing a number of either studies or work related to the balance that has to be struck between developing new parks and and those parks being located in areas that have poor air quality or near, highways and things like that. I apologize, I probably can't speak to that directly, but we are working with those at USC, Department of Environmental Health, on that issue.
Thank you.
Thank you. Well, if we have no further questions, let's thank Ms. Sung for your time. And if you want to send the documents to me, I'll ensure that the commissioners receive those follow-up
I will.
documents.
Thank you.
Much appreciated your presentation and your articulate explanation of actually a very complicated problem.
Appreciate it. Thank you for the opportunity.
Thank you for your time.
Thank you.
Next on your agenda is a presentation from the City Administrative Officer that we will not receive this evening, but instead are likely to receive in June. I made the mistake of confirming that on the agenda in advance of having completely confirmed their availability here, so I take responsibility for that. If anyone in the audience is here to see that presentation on agenda item number 1, 2, I apologize to you. That's going to come later on. We now have the pleasure of hearing from Mr. Adam Cohen on behalf of the AIDS Healthcare Foundation. Please join us here at the table. And again, same form would apply if you could make 7 to 10 minute remarks, and we'll quickly go around for a round of questions. It would be very helpful to all of us. Thank you for your time. Please.
There's 20 copies, so there should be plenty. Thank you, Mr. Sharp. Thank you, Commission members. I usually get to be back there, but I can now sit up here. My name is Adam Cohen. I work as a public health consultant for AIDS Healthcare Foundation. I also just turned in my doctoral dissertation to UCLA this week, and will hopefully defend at the beginning of May, and finally finish 8 years that I can't take back. But I study public health. I got a bachelor's in public health, a master's in public health, and 3 for 3 get a PhD in public health. And all I care about, for better or for worse, are STDs, sexually transmitted diseases or infections, and HIV. And I've been in Los Angeles since 2008, and the rates of infectious disease, particularly sexually transmitted infections, chlamydia, gonorrhea, and syphilis, as well as HIV, have grown. Disconcertingly so. And so I provide a one sheet. It's just a 2-sided piece of paper, very simple. I like to keep things straightforward. But the rates, and I chose rates, by the way, because rates take into account the size of the population, and also in order to stratify by years. And you can see for chlamydia, gonorrhea, and syphilis, rates are going up and up and up. These are preventable, and they're treatable. Actually, they're curable because they're bacterial infections, and the rates continue to go up. And just to share one little piece of just data, again, this is also available on the second side of the sheet. The number of cases for chlamydia have grown 17% in the past 4 years, from 44,618 cases to 52,098 cases. It's a lot. 51% increase in gonorrhea cases. 49% increase in syphilis cases. Again, this is just in a 4-year period. And as a little asterisk when it comes to syphilis, we were on the brink of eradicating syphilis back in early 2000. And now we have, I apologize for using AIDS Healthcare Foundation's campaign, but we have a syphilis explosion in Los Angeles County. And lastly, one positive note, and that's why I included it as the fourth point, is HIV is decreasing in Los Angeles County, but like any infectious disease or any actual public health issue, it's not necessarily that the rates are going down or the cases are going down, but we're dealing with situations where now certain populations are being more affected than others. So while it may be overall, we now have populations who most at risk for HIV that may need the most services but are not receiving those services. People who use intravenous drugs, people who are homeless, etc. So what are the predictors when it comes to sexually transmitted infections? I mean, clearly, these are people who are engaging in what are called risky sexual behaviors. In order to contract an STI, you have to be exposed to an STI. There's no toilet seat problems here with these infections. That was a bad joke, I apologize. So gender is a big predictor. In Los Angeles County, most infections these days are actually among men. My dissertation actually focuses on how while men account for the lower number of cases compared to women in the United States, men are actually experiencing an increase in the rates at a higher rate than women. So what we have here is, in Los Angeles especially, a disconcertingly high rate among men, and it's increasing. And I'll talk about that in just a little bit more later. Age is also a big issue, but this is a common theme. I mean, people who are 15 to 34 tend to engage in the risky sexual behaviors. We were all young once and may have done one or two things that we possibly don't look back fondly on. Race and ethnicity, and again, this goes back to my issues when it comes to HIV, you have populations that may be most affected. So for example, people who identify as Latino or Hispanic tend to be most at risk when it comes to the number of cases. However, the rates are actually highest among African Americans. And again, this is all in Los Angeles County. Lastly, of course, sexual orientation. So people who identify as heterosexual versus people who identify as gay, transgender, bisexual, etc., are more at risk for infections, particularly syphilis and HIV. And those occur mostly among men who have sex with men. Strategies. There are about 5 points I put together. There are many strategies being used currently to address this epidemic. However, I just put 5 simple ones. One includes, of course, healthcare services. We need to be able to not only test people, but notify people of positive STI test results, and then make sure they return for treatment. That is actually, surprisingly, a huge problem. And I don't know if many organizations have really mastered the art of notification. We actually, if you go to any clinic these days, they'll call you if the test results are positive. They won't call you if the test results are negative. And a lot of people don't answer their phones. AIDS Healthcare Foundation recently implemented an application called HealthVana that will notify people of their STI test results, much like getting a Facebook message. And I'm actually investigating whether that will improve the time to treatment. Next up, of course, condom use, correct and consistent condom use. Condom use is going down because we're just not advertising condoms, and nobody wants to talk about how condoms should be made available for free everywhere. Testing, of course, is improved in cost portability, it's improved in accuracy. However, if you go to the CDC website and you look at what the recommendations are when it comes to STI and HIV testing, for men who have sex with men, they recommend 3 months to 1 year get tested, depending on how many risky behaviors you're engaging in. For women, they recommend annual testing for chlamydia and gonorrhea. And for men who have sex with women, they recommend 1 HIV test in your lifetime. And that's it. Nothing else. And when you talk about, okay, well, heterosexual men, maybe they don't need to get tested because the women are getting tested. The people who are getting infected, if they are the women or the men, they need to get tested. We have potential, how do I put this? I put it down in here. Core transmitters. So someone who is engaging in risky behaviors and not getting tested, not understanding what they may be carrying, and infecting other people. And if that person is not tested and treated, that core transmission can keep perpetuating an epidemic in a local area. Last, two, of course, include partner notification, making sure that somebody who does test positive, that you notify their partners. The LA County Department of Public Health actually spends a lot of energy on that. And last, and my favorite in interest, is social marketing. Campaigns that move beyond just saying, know that there are STDs in the world, or saying, know that STDs are not worth getting, getting and worth testing for, but move it towards, let's get everybody tested. Let's incentivize people to get tested. Let's advocate behavior change and not just knowledge and attitudes. So what are the opportunities for this wonderful health commission? Number one is, we don't know what the data are in Los Angeles City. We only know Los Angeles County. I can make estimates based on the service planning areas that the LA County Department of Public Health uses. They use the service planning area 4, which kind of overlaps with the LA City. And I can tell you just very briefly from the LA County report, chlamydia in service planning area 4, it's Metro, it's called Metro Spa, has the highest proportion and rate of chlamydia compared to all other service planning areas. For gonorrhea among men, has the highest number, proportion, and rate of gonorrhea. For syphilis among men, again, Metro service planning area 4, has the highest number, proportion, and rate of early syphilis among all the different service planning areas in LA County. And HIV, the highest rate is in service planning area 4. So again, that's not necessarily representative specifically of LA City because we don't have data for LA City. And most disconcertingly, the report that was produced for LA City called the Health Atlas does not have sexually transmitted infections at all. It's not mentioned in there. HIV is mentioned once as an outcome of homelessness, but that's it, as a footnote. And that's disconcerting. Again, we have in Los Angeles County a syphilis explosion. We have high rates of chlamydia gonorrhea, and we still have high rates of HIV. So number one is collect data. Let's find out what is actually taking place in the city of LA when it comes to these infections compared to the rest of the county. Because just based on a rough estimate, it seems like there's a disproportionate amount in the city. Number two is collaboration. There are people who are on the ground. We're on the ground, but there are many organizations that are working to get people condoms, get people treated, get people tested, the whole gamut of the system in order to address high rates of STIs. But work with these folks to say, what can we do to help expand your services or make sure that you reach the people most in need? And the last point, and again, my favorite, is social marketing campaigns. We have not that many campaigns that are advertising getting people tested, treated, getting condom use out there. If you can think of a sexual health advertising campaign that is an AIDS Healthcare Foundation, I'd love to know more about it because I love researching these. We have billboards everywhere, but it's good to diversify, it's good to reach other populations. LA City too. There are no campaigns to really get people to reduce the risk of HIV and other STIs. And that's kind of what I wanted to share this time.
Thank you, Adam. Thank you for preparing this very useful overview. Questions from the commissioners? Beginning again on the west side, I guess, of the dais. Commissioner Hisrich.
John Hisrich. This is thank you for your presentation and your intense interest in this difficult topic. You know, when the AIDS epidemic was at its peak and the specter of death was very in front of folks, these issues kind of, I mean, the problems went down a bit because everybody, you know, now that the HIV situation is, you know, seen as not necessarily fatal in the near term, it sort of took some of the incentive away, I guess you could say. And we all know that campaigns against syphilis and gonorrhea and so on have been going on, you know, World War II saw a lot of them. Yep. And I think that, you know, the lessened anxiety over HIV has led most likely to less attention to prevention measures. And so I'm trying, this is an observation, but the tricky thing is how to link that together. You have to scare people a lot. Yeah. And, you know, syphilis is, while terrible, has not scared people enough, I think, in history. And I don't quite know how to develop a campaign that creates that set of incentives that were there a few years ago. So just an observation, really.
It's a good observation. The drug-resistant gonorrhea, which is growing, and unfortunately named super gonorrhea, which only has more of a positive connotation. I would think that looming fear would be instigating some sort of campaign akin to what occurred during the AIDS epidemic. But yeah, people are not scared anymore.
Yeah.
Oh, I can get treated. But the problem is the most common symptom. Does anyone know what the most common STI symptom is? No symptom. And these are the people that are most dangerous. They don't know that they're infected, and they're out. And obviously, because they contracted something, they may be already engaging in risky sexual behavior, and as a result, they're going to continue engaging in risky sexual behavior, and that's what makes them a core transmitter. Good observation, though. Yeah.
That's why I went to the UCLA School of Public Health for years.
It is.
No rivalries on the dice. Commissioner
Yes,
Andres
UC
Taylor,
Berkeley.
a question.
I would say that appreciate your comments, and I would be very interested in your move toward social marketing, particularly aimed toward behavioral change, which is probably the most difficult, as we all in public health know. And also wanting to know if there is a better way to, as you said, advertise condoms everywhere, instead of maybe a block within an elementary school. Because when I've gone by the local elementary school in my neighborhood and I see that ad, I think to myself, wow, I really would not want to have to explain that to my elementary school student. Fortunately, she's a graduate from college now, but just to be mindful of that.
That I understand. Yeah, thank you.
Other questions from the east side? Commissioner Vick?
Couple things. Sort of your point about the condom issue in general. I think one of the other problems I noticed is that in certain parts of the city, the condoms are locked up at the pharmacy. So if you're already scared or don't want to ask the clerk or feel judged, so I don't know if there's some sort of push that we can make to some of the pharmacies or whoever to unlock those condoms. I know they're concerned about them being stolen and those sorts of things, but I think that creates a barrier for a lot of people that will purchase, that maybe, they don't know that they're free condoms wherever, but they know they can go to the pharmacy, but they might not want to ask. The second thing I wanted to talk about, I know we talk about fear and scaring people. I don't know if that always works, because it's very easy to decide that you're not part of that population. This doesn't apply to me. And I wonder if there's any thought about or strategies of normalizing STD testing, opting out, or where it's like we do this automatically. This when you come in for your physical, we're not going to ask you if you want an HIV or STD test. It's going to be done anyway because we do that to everyone. And how do we get to that point where we start to normalize those types of services so it's not so taboo?
I love both of them. Just really quickly about the condom availability. I'm of the belief that condoms should be free. Nobody should ever have to pay for a condom. I mean, we produce our own condoms. We give them away for free. They cost us 3 cents a piece. So that, to us, we just give them away to anybody who could possibly take them. By the way, if you ever know an organization that wants a ton of condoms, let me know and we will ship them right over. But to make condoms available is just everywhere where people need them is the best idea. And I agree that locking them up doesn't help anybody.
Well, make them free in the pharmacy. I mean, see how that would work if you were to deliver a bunch of them to CVS and say, just put them on the shelf and say, these are available. I don't know, you'd probably have to pay for shelf space, though.
I like that idea.
Thank you. Dr. Mandel?
So every single time there's a positive test, the Department of Health Services for the County of Los Angeles logs the individual. It's when the lab comes positive, they track those. For the most part, they try to find the individual, or they go to the doctor or the clinic, and they get the information. They always have the zip code of where the person lives. Now, admittedly, some people don't live anywhere within a zip code, so there's a small percentage of the population that's positive that's going to be hard to track. But I don't understand if you really want to find out the LA City numbers. We know what the zip codes are. So just go to the Department of Health Services. It'd be a short app that would have to be written by the county to analyze their own data. And they, on a quarterly basis or a monthly basis or as often as you want to get your data, hit a little button and it should just spit out. We're talking about 6 diseases here. You're not really talking about every disease that the county tracks. So they should be able to do that reasonably inexpensively within their budget if it would be beneficial to you. Having said that, the county spends its money for the treatment of these STDs and other things, so they don't necessarily see a need for the city of Los Angeles to have the data. I think we could debate that, but the fact of the matter still is that they have all the data. It'd be very reasonably inexpensive to find it.
I would hope so. By the way, just to clarify for the other folks here, the people you're referring to are called disease intervention specialists, and their job at the LA County Department of Public Health is to make sure that when a new infection is reported, because the 4 infections I talked about in that paper, chlamydia, gonorrhea, syphilis, HIV, are all reportable infections. They have to be reported within a certain time period to the County Department of Public Health so that the disease intervention specialist can make sure that that's been tracked to say, okay, did that person get treated? And if not, can we track them down, meet them at the local McDonald's, and give them the medication there? Because it is worth our money and time to get that person treated than to let that person keep possibly infecting others. I think looking at the geographic data based on zip codes would actually be fascinating. And I'm curious, I guess I'm personally curious because I'm wondering what the burden is in the city of LA compared to the rest of LA County, and whether the resources are being put into the city of LA the way that it should be.
What I would actually say is a more political question is, if you're going to collect data, I'd collect it by congressional district. Because you're not going to get any activity until the members of the congressional caucus recognize the fact that it's in their backyard. It's always nice to say it's down the street or somebody else's neighborhood, but it's everywhere.
I noted that down. I like that idea.
Commissioner Jaquez?
Yes, first of all, congratulations on your your submitting that.
Nothing's done until the signatures are on the right piece of paper.
It's going to be fine. Trust me. So the issue, thank you so much on the presentation. I currently work for Ultimate Health Organization, and we've addressed this issue on several levels. One is the issue of HIV and AIDS, but also addressing the issue on a culturally competent way. And we just launched a program called, which was called Sin Influenza, focusing on a spin on the acronym of Living with Shame. It's the anti-living with shame. It was really interesting to go ahead and show the different perspectives of the Latino community and them actually being impacted by AIDS and actually living with the disease. So it worked out really well. If it's something that we want to talk about in the future, that would be great.
Awesome.
A side note, the other issue that we have is we have these clinics that are great specifically for HIV and AIDS patients, where they have their own facility and are able to go in, have their pharmacies there, as well as having that their counselors on site. So it's actually really a great opportunity for the different multicultural communities. If that's something that your organization is interested in working with, let us know. And then also we do the mobile units where we do go out in the communities, and we go to a lot of nightclubs, and we do provide testing as well as provide protection as well. So just to let you know, there's other we're out there, and if you want to partner, let us know.
That is awesome. I'm so happy to hear that. You go where the people are partying. That is the best move you can make.
Well, if no one else has any questions for Mr. Cohen, we want to thank you for your time. Thank you for being a regular participant in this process and informing us. We look forward to engaging you in the weeks and months ahead as we more precisely formulate recommendations for both city and county government. So thank you for your
I love it. Thank you.
I believe up next we have Dr. Olson Kennedy. Please join us. We appreciate you preparing an audio visuals. Gives us a chance to swivel in our chairs a little bit and get to learn from you about an important challenge facing the transgender population. If you could, again, try to keep structured remarks 7 to 10 minutes or so, and we'll do a round of questions afterwards as well. And
I was sitting in the audience wondering how I was going to advance the slides, so really happy to have the clicker. Thank you so much for having me here tonight. This is a topic that is near and dear to my heart. I'm the medical director for the Center for Trans Youth Health and Development at Children's Hospital here in Los Angeles. And I've been doing work with gender nonconforming children and transgender youth and young adults for the past 10 years and exclusively for the past 6 years, and here's why. So you can see in this graph right here that we have had an astronomical growth in the number of young people coming to our clinic for referrals. This is from 2010 to 2015. We have been doing this work at the Division of Adolescent Medicine. Our work with transgender youth grew out of our HIV care, and we just have had enormous growth. When I came to the program in 2006, I think we had about 38 young people in the program. We have about 640 right now, with about another 100 young people on the waiting list. It's not a phenomenon that's new to our clinic, but because of the fact that we've been doing the work for so long, we do have the largest trans youth clinic in the country, and actually probably in the world, but for sure in the country. Just want to show you this. This is referrals over the since January 1st of this year. We have added 61 new youth since January 1st, so if we keep up at the pace, we're really looking at having close to 1,000 kids in a very short amount of time. So I could spend probably 50 hours talking about gender, but I want to give you an overview of some of the things that you may not be aware of that are new to the landscape in youth care. So I see patients in between the ages of 3 and 25. So a lot of people ask me, what do you do with a 3-year-old? What do you do? How do you advise a family with a 3-year-old gender nonconforming child? So the answer is that before people start puberty, there's no medical intervention. Nothing is warranted and nobody should be doing anything. That would really be a problem because prepubertal kids don't have any sex steroids in their body, so they don't have any development of their secondary sex characteristics. By the time kids with gender dysphoria reach the beginning parts of their puberty, they start to experience extreme levels of anxiety, depression, self-harm, suicidality. There is just so much burning and cutting in this population. People are trying to cut off body parts. They are socially isolated, failing out of school, not participating in family activities. It's a very dangerous time for these young people. Probably seen that there are no small number of young people that have committed suicide in and around this puberty time period because of developing a body that they don't resonate with. So the Dutch are the ones that we really have to thank for this work because they've been doing trans youth care for the past 30 plus years, and they were the ones that said, is there a way that we could keep people from developing into the wrong body, and could we save lives by doing this? So they use this medication called GnRH analogs to stop the process of puberty, endogenous puberty, and then they add hormones at 16 years old and surgery at 18. So basically, the idea is to stop the production of estrogen and progesterone from the ovaries or the production of testosterone from, I'm trying to advance on this, sorry, on the production of testosterone for young people that identify as female. So when you move forward and young people get older, they can add hormones to induce female secondary sex characteristics or male hormones to induce male secondary sex characteristics and only have to experience puberty one time, which is really different because for adult trans folks, they went through one puberty and then as a medical provider, you have to go backwards, and that's actually impossible in a developmental world. All you can do is give people hormones and then perform surgeries, which are often really expensive. They're cost prohibitive for most people, and for a lot of people, they're not even necessarily helpful. I want to show you, this is a picture of some of the young people in my practice who have really generously let me use their photos, but what you can see is these are young people whose physical gender transition started early or they were blocked from going through their endogenous puberty process, and now they have the gift of selective disclosure. So they have the opportunity to disclose or not disclose that they are transgender individuals. And for many of these folks, that's life-saving. I don't have to probably remind most people in this room that being identifiably trans, particularly a transgender woman of color, puts your life at risk every time you step out your door. And so having this gift of selective disclosure is very life-saving for folks. I want to show you, and you're probably, this is not a mystery either. This is the Los Angeles City racial ethnic census data that shows a kind of our breakdown. Obviously, it's not complete, but it gives you a general idea. But I'm showing this so that you can compare it to the ethnic breakdown of folks who are getting blockers across the United States. there is a disproportionate number of white kids who are having this opportunity to have their puberty blocked, and that is not extending to young people from communities of color. And we have just embarked on this journey to figure out why this is. We don't know why, but the scary part about this is that in 25 or 30 years, the only identifiably trans people will be trans people of color, who are already at a disproportionate risk for losing their life and being injured by violence at the hands of other people. So this is a really crucial moment in time, because as the blocker protocol is such a new intervention that we can provide for young people, we have to make sure that we're not contributing to a double disparity now for trans youth of color. So the question really is, and in Los Angeles, we have such a diversity. We have this opportunity to really understand why this is happening and why we're not seeing trans folks that are younger from communities of color accessing care. While lots of people come from all over the country to get care at Children's Hospital Los Angeles in our center, 95% of them come from within 20 miles of our center. So out of those 650 kids, most of them are from the city of Los Angeles, or very close by. But what I know to be true is there is such a small number of young, in fact, the only African American kids in my clinic that are blocked are adopted by 2 white same-sex couples. And that's really unfortunate, and that's a big problem. What are some of the barriers to care? We can anticipate that some of the barriers to care are lack of conversations in certain communities, little or no information about gender diversity that's included in the school curriculum. So this is, even though we have mandates about including gender diversity and talking about trans experience, I'm not certain that it's happening. There's a huge lack of information about where to even get care, what interventions are available. A lot of people still think you can't do any medical interventions until you're 18 or sometimes 21. That is not true. There is care available for younger people, but that's not widely known. There's also a huge lack of available mental and medical health professionals who feel comfortable doing this work, who are competent doing this work. I mean, I manage 500 patients myself in the clinic. I'm incredibly busy. I never have a minute to do anything, but I absolutely work tirelessly to train people to do this work. But in Los Angeles, there's myself and there's Kaiser, and Kaiser's not doing a super good job. So we really need to think about training people to do this work. And then getting into communities of faith and helping, because sometimes communities of faith are rejecting of transgender kids and their families. And these are families that have constructed a lot of their life around their faith communities. And so they are forced to choose between their child and their child's authentic self and their community of faith, which puts them into a really difficult situation. Here's another piece that's really important. California is an amazing state to be in because we cover care related to transgender physical transition. But look at what's covered for transgender women: hormones and genital surgery. But look what's not covered: facial feminization, breast contouring, electrolysis, and hair removal that's necessary for genital surgery, and tracheal shaves. All of the things that are not covered are things that identify people as transgender, and they put people's life at risk. So we have to work on changing the way that we ask our insurance companies to cover this care. The last thing I want to talk about really briefly is transgender youth that are in foster care. We know that LGBTQAI people are disproportionately represented in foster care. Approximately just under 6% of foster care youth identify as transgender, which is huge. The estimated prevalence of gender dysphoria or trans experience about 0.3 to 0.5%. So you can see this is 18 times the general population. So there's a huge disproportionate representation, in particularly trans youth of color. Trans kids are also more likely to live in group homes because of the nature of who does the fostering, the lack of understanding about trans kids, and they're also more likely to report being treated poorly in foster care. These are all problems because there's an issue with how they're treated when they get in the system and how they're treated once they get placed, and there's an issue with permanency as well. What needs to happen? Efforts have to be made to identify barriers for trans youth of color. That is first and foremost on my list of to-dos. Increase information in educational curriculum in the elementary school and middle school. I appreciate not wanting to explain the AHF billboard to your elementary school kid, but I also understand that elementary school kids are talking about things. They're talking about gender, they're talking about sex, they're seeing it on TV, and so these are places where we really need to improve our curriculum. We have to engage communities of faith so that young people and their families are not rejected from those communities. We have to encourage competent and timely care for trans youth and foster care. We need that care to be turned around quickly. We need it to happen. The courts need to approve care if there's still medical custody maintained by the parents of those young people. And we need to have trans people at the table. When we're crafting curriculum and legislation that affects trans youth, we need to make sure that we leave seats and invite trans people to that crafting of that legislation and those access to care issues. And we need more resources to be allocated for transgender youth care so that we can not have to get on a plane in order to get care or even significantly travel a long distance to get this care. I just want to, this is special thanks to my amazing husband who teaches me lots of stuff, but my boss and my facility, but really everything that I've learned, because I've probably taken care of more trans kids than any other human being in the world, and they are the most amazing teachers, and they've taught me everything that I know, and I would love to bring some of them here to talk to you all someday, because they are remarkable teachers.
Well, thank you, Dr. Olson Kennedy, for preparing this very illuminating overview for us and going through it quickly. It provokes a lot of thoughts. And wanted to open the floor for questions from the Commission. Commissioner Vick, please, take the mic.
How do the young people get to you? Like, is there a flyer? Like, how do they know, hey, let's call this lady?
Yeah, that's a great question. I do a lot of media. I'm not necessarily a fan of media, but I think it's the way that people get educated and it's the way they get information. So I do a ton of media talking about trans youth and what their needs are. So some people see me on TV, some people see me through the internet, but I also talk at conferences. I do give grand rounds at hospitals all over the country. So people meet me at conferences, family conferences, things like that. But hopefully people can go to their own pediatrician who would know about us and refer them, but that doesn't always happen, and pediatricians do not have the knowledge, and they don't even sometimes know where to refer. Sometimes kids are like, well, we've been looking for 3 years, and they live 10 minutes from my clinic.
Wow.
Yeah.
Okay.
Commissioner Hisser.
Hi. Just a question. Adolescence is a difficult sorting out time. Is there an inevitability to this, or if a child is struggling, do they get dragged into it? Or I'm just struggling a little bit with that. I mean, how does one know, if you will, that that's the direction that you and everyone should be going with the youngster?
I think that's a great question. I mean, young people have a pretty significant process before they land at my door. And even though I do see people that are quite young, it's pretty rare. The majority of people that do come, the average age is around 16 or 17. So they've gone through quite a significant process. The trajectory is not definitive either direction or any direction, because there are certainly many directions that young people can develop. For people that are younger than adolescents, so people who are prepubertal, who have gender dysphoria, have a wider range of trajectories where they may go. But by the time people reach adolescence, what our data is telling us, and the data from the Netherlands, is that people actually are transgender, and that's their trajectory, and that early treatment is really beneficial for them.
Additional questions. Dr. Mandel.
Thank you. Thank you for an excellent presentation. So if you look at Children's Hospital's demographic, this is a significant percentage of patients that you see, or as an institution, is Medi-Cal or governmentally supported. Is that true of your clinic as well, or is you're an outlier in comparison to the other excellent programs at Children's Hospital? And if so, what does Medicaid, Medi-Cal pay you for consultation and or ongoing therapy?
So I am a complete outlier. I am one of the only clinics in the Children's Hospital that has 70% private payer insurance, which speaks to this problem that I'm talking about. Medi-Cal is actually covers services. I mean, I don't have to tell you all this. Nobody reimburses anybody what they actually have to pay for clinical care. It's very frustrating. I'm actually not completely clinically supported in my work. I have an NIH grant with 3 other major programs around the country looking at the impact of care in youth. It's a big problem because we have shoestring budget to do the work that we do, and if I can't imagine what we've been doing if we were actually funded. But so the reimbursement is terrible. It's notoriously terrible. But the good news is that Medi-Cal covers trans-related care in California. It's actually, sometimes I feel like, oh, I wish you had Medi-Cal because this would be covered.
So in comparison to, say, a private payer, what does Medi-Cal pay you for a full consultation or alternatively for a follow-up visit?
I'm not certain. I try to stay away from information about reimbursement because it hurts my soul. I have to do other, I'm not the person that would track that in our clinic at all, but I know that we would be very, very happy and welcome many more Medi-Cal patients. I think we're underserving Medi-Cal patients in Los Angeles for sure.
Well, statewide, 35% of the California population is Medi-Cal, and in LA County, I don't know LA City numbers, but in LA County, it's more than half.
Yeah. Not reflected in our clinic for just the reasons that we're talking about.
Other questions from the commissioners? Well, Dr. Olson Kennedy, thank you for your time. Thank you for coming downtown here to join us, and we hope that your work is reflected within the work of the recently convened City of Los Angeles Transgender Advisory Council that the city council members who appointed us have also put together. And so we look forward to collaborating in the months ahead.
Thank you. Thank you so much for having me.
Thank you for being here.
And on agenda item number 1, we have a comment from Mr. Herman. The public comments this evening are expected to be within the jurisdiction of the committee and of pertinent and relevance to the discussion that we have had under agenda item number 1.
So as you may all want to know, tomorrow's closed session regarding Independent Living Center of Southern California versus the City of Los Angeles and your plum, fuck you, Jose Huizar and your plum, for the actions of community redevelopment agencies taking advantage of the public. All our funds. Fuck you, Jose Huizar and your plum. Anyone involved with development taking advantage of citizens, more so the homeless, fuck you.
Please make your comments of relevance to the agenda item we've been discussing.
To the item regarding housing. And housing is for all who need housing. The homeless population, like myself. Fuck you, Jose Huizar, for my homeless issue. And so, as we read in this document, concerned U.S. Department of Justice investigating the Conviction of Fair Housing Act, ADA, and Rehabilitation Act of 1973, fuck you again, Jose Huizar, and your plum, for your development in the CRLA, taking advantage of the public.
Mr. Herman, this is the Health Commission. If you have remarks regarding the jurisdiction of the Health Commission, we'd be happy to hear those comments now at this time, but this is not the Housing Commission.
It is. It's involving why there is no concern to look into the allegations brought against those who live in the city by certain criteria of people in the city who do the business for the people to steal for people. Where the fuck are the housing at? We've been discussing housing for how many fucking years? Not one fucking thing done. That includes you, Mayor, and it also includes the other assholes involved with it.
Thank you for your remarks. Item number 2 we have is discussion. Mr. Herman,
we need housing. You're listening, Mayor Eric Garcetti.
you please cut the microphone, please.
You've done shit for all of us in the city of Los Angeles other than making it
Please
harder
cut the
to live
microphone.
in
Thank
Los
you.
Angeles. I took my 50 seconds under the Brown Act.
Discussion and/or action to evaluate the city's agreement with the county to provide enforcement of the Public Health Code. As all remember, this agreement was a bit mysterious and hard to get a copy of and pin down. And we eventually circulated a copy of it as it is part of our initial ordinance for those watching to make and listening on the World Wide Web across the world, to make a judgment and a recommendation to the City Council regarding whether this agreement ought to be changed, whether it ought to be continued as is. It's been in place for 52 years almost now, and we have a copy for you in your packets. Thank you to Clerk for providing that. And we've been assigned to take action on it, and I'd love to lay out a possible method to formulate a judgment and to reach a decision to advance back to City Council regarding whether to continue this. And so I wanted to pause and let you know that's what this agenda item is here today. And my suggestion is actually perhaps too simple. I would like to have the Commission agree that we ought to simply survey the city departments that interface with the county on the public health code, and to ask their appraisal of whether the current arrangement and the agreement as described in this 1964 document still is of use to them and meets their objectives as it relates to their scopes of work. And so just a very simple survey. Do that in the next couple weeks in concert with Clerk and City Administrative Officer, who've provided some consult on this, and potentially come back with a recommendation to the group that city departments are pleased with the current division of labor, or a number of city departments have concerns that we ought to really discuss and act on in a robust way, or if, as I hope, we learn that the current division of functions between the city and the county are both effective and well appreciated. So that's just the simple process I'd love to lay out and get reactions and input on.
I just have a question in regard to it, having looked through this agreement. It looked like the only exchange of money that was envisioned was if the court appearances by county employees to deal with city matters had overtime or related things. I wonder, has that ever occurred? Has the city ever paid the county for having some county employee appear in court in defending these? I mean, it just seemed odd to me that maybe we haven't even played the other side of this.
The City Controller's Office has compiled those expenses. It's a very nominal amount of money, and they're going to send it to me in a PDF form that I can include back with everyone.
There have been some payments.
There have been some very small payments. It's of nominal. They weren't even aware that it was going on until they searched through their own database and found that a small number of payments were being transferred.
Okay. And the enforcement issues are enforcement of county public health regulations, if you will. I'm not aware of separate city public health ordinances that would be at issue here.
Well, there's ordinances the city has adopted, for example, regarding the use of tobacco in parks.
There are those, but I'm not sure if those would, well, I think one that clearly comes to mind, the restaurant enforcement has to be chosen city by city within the county. In other words, a city can opt into, I believe, to the restaurant inspection program because some cities don't. And so I just wondered if that, maybe that's another issue related to it.
You want to come up? We have Joshua Bobrowski here from County Public Health, who's been our liaison. You may be able to provide some technical expertise in regards to this discussion, and we'd welcome any of your reactions to the general outline I laid out as to how we might approach this assignment in our ordinance. Please sit at the table, if you may. Other commissioners, in addition to Commissioner Hisrick, some thoughts, reactions on how to approach this task, other than a simple survey of departments?
Do we need to make a motion to have that done, or is the City Administrative Office going to do that anyway?
What I believe is the process is we need to make a motion at some point to recommend back to City Council whether to continue the agreement as such. But for the process of a simple survey, I think that can be enacted by virtue of the original ordinance prescribing that as an assignment to us. So we're tasked with investigating it, and it's just a method to do so. If you'd feel comfortable for us,
I think we should.
Taking a
I was
motion
going to say that I think we should make a motion and vote on that. Though I don't see any opposition, but I still think that from a legal point of view, we should probably empower the agencies to do that. So I would make the motion to approve what you've suggested in item number 2, that the city agencies meet and study to come back to us.
Do we have a second?
I'll second it.
Great. All in favor?
Aye.
Opposed? Abstain? Great. So the motion is moved as passed for clerk to empower the Health Commission to engage city departments to evaluate the current health services agreement with the County of Los Angeles. I think that's the language. Thank you, Dr. Mandel. Are there any technical questions regarding this arrangement that, or discussion for commission and or anything for Mr. Bobrowski?
About how many city departments would it be? Do we have an idea?
I've currently identified 6, which is sanitation, fire, police, recreation, and parks, and 1 or 2 more that on the record I don't want to boggle, but there's about 6 departments that appear to have some overlap. Housing, building, and
Housing,
safety.
I think, would.
And the city administrative office has been a real collaborator in trying to think this through, and so it's a very simple Google form survey that I intend to circulate so that the results would be available to all the commissioners easily online. We don't have to go through it.
Airports also.
The airport may have a role. Any comment, suggestion from, why don't you first of all introduce yourself?
Sure, Joshua Bobrowski with the Department of Public Health for Los Angeles County. And the approach that you outlined sounds reasonable to me in terms of surveying the city departments and finding out their perspective.
And then we look forward to, sharing any responses that would be surprising with you in advance of the next meeting in case there's any value to discuss. Otherwise, we should probably be able to recommend back that this is working. And certainly from your vantage point on behalf of the county, it's a 52-year arrangement, and so we'd like to believe it's working.
Sure, and if there's ever a value of having the county health officer, interim health officer come and answer questions as well about the statutory duties and the duties under the contract, we'd be happy to have them
Thank you,
attend
Joshua.
as well.
Any further on this particular agenda item? Great, thanks for your efficient and quick work on it. We have a public comment on agenda item number 2 from Mr. Herman, and again, we're reiterating the expectation that the remarks are within the jurisdiction of the commission. We'll empower the sergeant at arms to cut things off rapidly if we don't adhere to that. So the topic we just discussed was the agreement with the city and the county on the public health code.
Now, since we're talking about housing and safety under public health code and referring to ordinances, let me remind you that, again, the CRLA has been so defiant that it robbed us of housing. It robbed us of the safety protected by code and ordinances. Why? Who allows this bullshit to go on and take advantage of us under such terms under public health? Isn't our housing and safety part of our public health? That's the reason why tomorrow under Civil Case 120551, we're going to talk about housing.
Sergeant at arms, please.
Safety of discussion.
He should be directing his comments to the item number 2 on the agenda of this board meeting. If he doesn't, he's off topic.
Sergeant at arms, please. Thank you. Agenda item number 3, items for future discussion. We have the opportunity at our May meeting to hear from informative presentations such as the ones we've benefited from this evening and in previous months, and I and others are open to hearing those recommendations at this particular juncture, as well as at any time between now and more or less a week or so before the meeting when clerk begins to prepare the agenda. So certainly feel free to suggest any subject matter expertise related topics that we ought to try and bring someone in on. Additionally, I'd love to propose a couple items that we might actually take a vote to ensure end up on the agenda for next month to continue advancing the Commission's business to achieve the assignment and tasks required in the original ordinance that brought us here together in this motley crew. And so with that, I'd love to propose that we agendize for our May meeting a discussion of a staffing plan and the scope of work needed to complete our original assignment, as well as to respond to a subsequent City Council motion adopted last week by the full City Council and enacted into law. Council Motion 15-1514 requires us to engage with City Clerk and City Administrative Officer to develop a staffing plan and make some recommendations regarding the sort of resources needed to complete the objectives. And
Can
so
I make a motion that that be put on the agenda?
do I hear a second?
Second.
All in favor?
Aye.
All right.
Any opposed? Sustained? So we have that as an agenda item. Clerk, appreciate you taking that note down. Other agenda items that we ought to plan in advance to take up at our May meeting?
I think the suggestion to hear from the Director of Public Health about the 1964 agreement would be good.
Let me offer this, Commissioner Vick. Is it possible we ought to take a look at the responses from the departments to determine whether it's in effect a good use of, I believe you mentioned Chief Health Officer Dr. Gunzenhauser is a possible. My suggestion would be my reaction would be let's try and see what comes out of the survey in advance of inviting them in.
Sounds good.
If there are significant concerns raised by city departments, we ought to engage them in a constructive way to prepare the right presentation to respond. I'm aware that Dr. Gunzenhauser is covering a lot of areas and want to make good use of his time.
As we know, there's health disparity throughout the city of Los Angeles. A lot of that is related to economic reasons, and some of that's also related to provider deficits. I'm wondering if that's whether it may or at a future meeting we potentially could be presented to on the numbers of physicians, nurses, and occupational physical therapists, et cetera, that provide services in the city of Los Angeles, and if there's something the city can do about increasing those numbers.
Excellent. Within our prescribed mandate is to identify the health needs of city residents, and close proximity to adequate physician and medical care is obviously a fundamental need. So we ought to get a good map of what that looks like.
And I'm assuming one of the schools of public health, I mean, we do have some excellent schools of public health, and that potentially would have somebody who's an expert on that, and or there might be somebody from the county health services that actually has studied this.
Terrific. Let's make sure we take that up in May.
So your specific information you want is the workforce issues then?
Well, like a presentation potentially that what the real problem is. I mean, are we short surgeons, say, in the city of Los Angeles? Are we short pediatricians, whatever the case might be?
Sound useful? Other subject matter to make sure we act on to take up in May?
Wanted to have a chance to look at, again, some of the reports that are already out there, the City Health Atlas, the plans that are there so that we're not recreating the wheel. Since we also have to do a report, why don't we see, just kind of get our arms around some of the data that is available, and then maybe we can identify if there are still gaps that we could fill.
Great. If we are afforded the liberty of some staffing resources, that would certainly be an important task for that individual to undertake, and perhaps we can get a little start at the next meeting in scoping out what the universe of data is to stare at more closely. I think there seem to be at least two other commission business items that are worth raising. One is we have certainly one vacancy due to the unfortunate passing of former council member Rosendahl, and there's two others that have never actually joined us, I believe, from the attendant rosters in terms of appointees. And so I'm not certain whether we need to take it up as a commission or whether we can work offline to re-engage those council offices for them to determine whether the initial appointee is able to make the commitment or whether they need to solicit other residents from their district to potentially make it. We're now down more or less 3 consistently, which makes it much harder to reach quorum, particularly as we get into the process of identifying priorities meetings. We need to have a robust and full team of folks that have been on board throughout the whole process. So I'm not certain. I seek your guidance as to whether that process can happen without the commission taking action, i.e. reaching out to the 3 council offices, or whether we need to do something in May.
Let me go ahead and look into it, and then I will go ahead and let you know. I need to go ahead and check.
Thank you, Candy.
The other thing, what I would suggest in that is that those 3 city council offices should potentially, if they don't have somebody off the top of the head that they would really love to nominate, go to the schools of medicine and or the schools of public health and or the schools of nursing, of which we also have some excellent schools of nursing in this city, that potentially can nominate somebody who lives in those districts who is knowledgeable, has expertise, and can offer something to the commission.
Great.
Let me go ahead and look into it, and then I'll let you.
And I'm happy to make myself a resource to any of those officers who sort of want to find out what we've been up to. It's been a little while since the original request went to them, more or less like a year and a half. so it's very possible it's no longer a fresh topic, so I'm happy to help with that as well. And then the other item of Commission business we probably ought to take up in May is...
Commissioner,
Oh,
I had a
sorry,
question.
Commissioner Jaquez.
No, in respect to, I'm glad we're adjourning in memory of the former council member. With that as spirit of leadership, are we going to discuss, now that we're about halfway into this organization, to this commission, are we going to discuss, once we find out the outcome of the 3 positions, discussing leadership opportunities? Will that be something, an item that we can discuss?
Well, we certainly can plan to agendize that for May. As you can see, I'm the only one of the original 3 officers identified who's available here tonight, so it's probably valuable to revisit those slots and make sure that we have adequate leadership, and or as the process goes forward, some folks may want to raise their hands to be involved in a way they didn't before, and some folks may want to take their hand out.
Thank you.
So that would be a great topic to do in May.
Thank you.
Otro negocio, other business?
Oh, actually, Commissioner Sharp, I'd like to bring up the issue of the CAO's report on homelessness.
The city administrative officer has, or officer's office has communicated their unavailability for the May meeting due to city budget hearings. They requested to come back in June. What I can do in the interim is circulate the executive summary of it. It's a really well-written document, and from like a template standpoint would be a great model for us to follow in terms of how they organize their recommendations. It's really clear and easy to read, as well as actually of much relevance to the discussions that we've been having. So I'll circulate that in the interim, and unfortunately we won't have them with us until June.
What about the county?
The county's homeless plan is moving forward, and I acknowledge that neither I nor do I believe Commissioner Shannon has reached out to them to solicit their participation in the setting. If you believe that's valuable to undertake for May, we can reach out.
Okay, great, thank you.
If we have no further discussion, Commissioner Esparza, you're on the cusp of a statement. Great. If we have no further discussion of items for future discussion, we have a comment card from Mr. Herman on agenda item number 3, and we are entertaining comments regarding the future discussion items that we have recently just discussed.
Yeah, I'd like to make a motion that on the next meetings that you announce the name of the absentee commissioners, so that way we are aware whether or not we have a full quorum. And also at the next commission meeting, I would like a motion to advise the public that regarding information on homelessness, it should be an open transparency to discuss the matter at, I would suggest maybe like at council meetings on Tuesdays and Wednesdays and Fridays at 10 a.m. So that way the council is aware that there exists a so-called health commission that deals with issues on public housing, public safety, and other non-agenda miscellaneous asshole items that I don't want to talk about right now. But that's my recommendation. And I'll reach out to my friend Bill Rosendale. My condolences. I'm sorry that you only made it to one of our meetings, and I'm glad we opened it and closed it with you. Maybe in the future, as I reach out to you on the Zuzu land, we will have a connection. And that connection is that on our day of haunting, we will not stop or cease, but exist in the minds of those who despise us and deceive us with their cowardly actions to protect our significant understanding.
He appears to be wavering from agenda item number 3.
Herman.
Discussion for motion, sir. And before the gentleman interrupts me, let him know that it's a Brown Act violation. Wait till I'm done.
Thank you for your comments. I was reminded by clerk that we did not entertain a motion to establish the other the topics that we had previously enumerated as future agenda items, so to ensure that they move seamlessly onto the agenda for the May meeting. Do I have a motion to? We had 3 here. We did do one on the staffing plan. We need to do a motion to commit us to discussing provider access throughout Los Angeles. So do I have a motion to do that?
So moved.
Second?
Second.
All in favor? Aye. Opposed? Abstain? So passes. Do I have a motion to select officers at the May meeting, to revisit the leadership slots for the Health Commission at the May meeting? Do I have a motion?
Well, I'll make a motion that we not select officers, because we already have officers, but one would move up the first vice president to this role of president, second vice president to the first vice president, with the assumption that Commissioner Shannon would want that position, and then elect another individual to replace yourself as the second president, vice president.
So do we have any discussion of the
My motion has to be
I guess?
seconded first. Second. Or not, it'll just die.
I mean, my suggestion would be that we keep it general to have a placeholder for the discussion as opposed to a specific action on a specific slide. But I'm happy
But no
to
one seconded
hear.
my position, so my motion. So if nobody seconds it, it dies. And then you could make your motion and you'll get a second.
So on Dr. Mandel's motion, do we have a second?
No, we don't.
No, we
Yeah, we
haven't.
don't have a
It's
second.
dead.
Oh.
No, we don't.
Okay, there is a second then. So now you have to actually vote on it.
So on Dr. Mandel's motion, just to be clear so everyone knows what we're voting on, which is to open up basically the second vice president slot, do we have...
And move everybody else up.
And move everyone else up. So that's the question on the table for the next meeting. All in favor?
Aye.
All in opposition?
No.
No?
Nay.
I don't know.
And abstain?
I guess I'm abstaining because I don't know.
So I think I need to do a little count to make sure.
There's 4 noes, 3 affirmative, and 1 abstaining. So if there's 8 of us voting, that would be
That
the
would be
number,
the
so
count.
it's voted down.
Right. So we go back to the original motion, which was to select officers at the May meeting.
To open to discuss
Open to discuss that.
the leadership roles in the commission.
That's different than what he just said.
Yeah, no, that's what I'm intending to propose. Please state more clearly, Commissioner Jaquez.
To open to discuss with the current vacancy, the leadership roles and opportunities in the commission.
Any discussion? Seconded by Commissioner Hisrick. Any discussion?
If I could, I'm not opposed to that, but then we won't have resolved the issue of not necessarily having leadership at a potential meeting if either yourself or Commissioner Shannon is not here. So I'm not opposed to having the discussion, but it does leave the potential that we'll have no leadership, which is fine. We can select at one meeting somebody just to kind of run the meeting, but one would think that would be a potential problem.
Which
we should resolve it at the next meeting.
Yes.
We could discuss it and resolve it, but I would kind of a friendly amendment to your motion would be that not only do we discuss it, but we get resolution at that meeting.
Agreed. Discuss and take action is how we've been wording this in the language. So discuss and take action to fill the leadership slots at the May meeting.
Okay,
So moved.
I'll second that.
Okay. Discuss and take action to fill leadership slots at the May meeting, just so we're all clear. All in favor?
Aye.
Opposed? Abstain? Moved as passed to be agendized for our May, I don't have the date off the top of my head, gathering in the year 2016. So I appreciate Clerk reminding me that we needed to walk back through that. I apologize for the sequence out of order there. Appreciate Dr. Mandel careful listening. And we are now on agenda item number 4, which is public comment regarding any and all matters within the jurisdiction of the Health Commission. And on agenda item number 4, we have a comment from Mr. Zozo.
Well, here we are, we're talking about 12/0551, item 15 of tomorrow's council meeting, an investigation in connection with the Fair Housing Act, ADA, and the Rehabilitation Act of 1973 for compliance matters brought against Independence Living Center of Southern California versus the City of Los Angeles. This city council shall recess to a closed session to discuss the matters of importance of how you violated our fucking rights, assholes.
Any comments in the matter of the jurisdiction of the Health Commission?
That is of importance. It involves my fucking health to have housing, not for myself, but for every fucking person living on the street and the sidewalk, meaning homeless people. I come here today to advocate for homeless people because they have a right to live in a fucking house. But now the Department of Justice is gonna screw the fucking pants out of you assholes, the city councilman, and you ex-mayor councilman, Eric Garcetti, for fucking things up under the CRA-LA.
Mr. Zozo, please make your comments relevant to the Health Commission's jurisdiction.
Mr. Zozo is reading it right off a city agenda. I'm on fucking time, topic on non-public comment time. And I will institute my right under the 54-950 Brown Act to say, fuck you, fuck you, fuck you. For this reason, we are having a hardship and harm in our city, brought by you assholes who don't listen to the public. People who suffer mental health, people who suffer from AIDS, assholes. So get your shit together. That's why Bill died. That's why eventually that O'Farrell and that other faggot Bonin might die for having AIDS, motherfuckers. So don't tell me I'm off topic. I'm not upset. I'm just voicing my fucking opinion about you fucking crooks in LA.
In honor of former Councilman Rosendahl and Commission President Rosendahl, we adjourn the April meeting of the Health Commission. Thank you to clerk staff and to Sergeant Arms, technical staff, LAPD for joining us here, and to the members of the public. Good night.